Bismillah ar-Rahman ar-Rahim. In one-page approach, we will discuss how should we treat pulmonary embolism. And we start first by the general scheme. The general scheme started by the assess the risk of mortality of the patient. If the patient has hemodynamic instability, which is defined as patient with persistent hypotension, systolic blood pressure less than 90 millimeters of mercury, or the patient on vasopressor support, or the drop of the systolic blood pressure more than 40 millimeters of mercury for more than 15 minutes, or the patient develop cardiac arrest. Any of these factors, the patient considered to be high risk patient. But if the patient is not in any stability, the patient is hemodynamically stable, we need to assess three parameters. The first is simplified pulmonary emergency severity index score, sign of RV dysfunction, and the cardiac biomarkers. And based on these three parameters, we categorize the patient into three categories: either low risk patient, or low intermediate risk patient, or high intermediate risk patient. If the patient, all the three parameters are positive, this patient is at high and will be considered high intermediate risk. If all three parameters are negative, the patient considered to be low risk. Any combination of these factors, the patient will be considered as a low intermediate risk. The second question for patient or for management in this patient is where should I treat these patients? For high risk patient and high intermediate risk patient, the patient need to be admitted to the intensive care. For low intermediate risk patient, the patient can be admitted to the hospital ward. And for low risk patient, the patient can be discharged safely to the home. And the last question is, how should I treat this patient? For high-risk patient, this patient need immediate reperfusion therapy, either by pharmacological or surgical or catheter-directed therapy. For high intermediate risk, the patient started by low molecular weight heparin or fondaparinux, but if the patient develop hemodynamic instability, the patient will need immediate reperfusion therapy. For low intermediate risk, the patient will start low molecular weight heparin and fondaparin or fondaparinux and then switch it to the oral anticoagulant. And for low risk patient, the patient will start can start oral anticoagulant from the beginning. So the core management of pulmonary embolism depend on the risk stratification, and the risk stratification equal probability of mortality. And the risk stratification, again, risk with hemodynamic instability, this patient should be considered as a high-risk patient. Risk without hemodynamic instability, we should assess three parameters: simplified pulmonary emergency severity index, RV function, and cardiac biomarkers. Let us take some example. If we have 70-year-old male patient, saturation 95% on room air, blood pressure 110 over 50 millimeter of mercury, heart rate 90 beat per minute, no history of cancer or cardiopulmonary disease, both troponin and RV function are negative. And according to this parameter, the patient has no risk score on simplified pulmonary emergency severity index, and both RV function and cardiac biomarkers are normal. And this patient considered to be low risk. This patient can be discharged safely to home, and he can start new oral anticoagulant or vitamin K from the start. Let us take the next example. The next example, the patient, 60 years old male patient, saturation 94% on room air, blood pressure is normal, but the heart rate is 110 beat per minute. Troponin is positive, but the RV function is normal. The heart rate is 110 beat per minute. This take 1 point on simplified PESI score. And this patient lying in the middle category, he considered to be a low intermediate risk. He need hospital admission, and he need to start low molecular weight or fondaparinux. The third patient, 55 years old male patient, hypoxic on room air, blood pressure and heart rate is okay, but both troponin and RV function are impaired. Both troponin is positive and RV function is impaired. And according to these parameters, because the saturation is less than 90%, this patient will take 1 point in simplified PSI score. And he has both RV dysfunction and positive cardiac biomarker. So this patient considered to be at high intermediate risk. The patient will start on low molecular weight heparin or fondaparinux, and we watch out the patient. If the patient develops hemodynamic instability, the patient will need immediate reperfusion therapy. And the last patient, if the patient with hemodynamic instability, low blood pressure, and the patient is on vasopressors, so this patient is at high risk of mortality, and this patient will start first by IV heparin, and we go through the immediate reperfusion therapy. The reperfusion therapy depends on the contraindication to the thrombolysis. If there is no contraindication to thrombolysis, systemic thrombolysis, the patient will receive 100 milligram of TPA infusion over 2 hours. If the patient has a relative contraindication, he can be treated with catheter-directed thrombolytic therapy. If the patient had absolute contraindication to the systemic thrombolysis, he has two options, either surgical embolectomy or catheter-directed clot extraction. And for further reading, you can check the guideline of the European Society of Cardiology that was published in 2019. Thank you.